Rick, now we'll talk about the clinical. So this is the last part of all of the exams. There's 2, is that correct?
2 clinicals, yep.
And what is the format of the clinicals and how do they present?
The clinicals are slightly different. It's not like OpSurge 1 and 2. So for the first clinical in the morning, it's a 4-patient or full 4-question exam for distinct patients. And then for the second exam, second segment, it's 3.
Mm-hmm.
And that's designed to look at more an interpretation of clinical signs, an interpretation of history, an interpretation of how a patient presents physically in the first section, and a bit more depth in the second segment.
Mm-hmm.
So when you're doing only 3 cases, so you might have a little bit more of the scenario building and management in the second section. But again, I wouldn't be going in there expecting a certain format, saying I'm going to give short answers in the first bit and longer answers in the second bit.
Answer the questions.
Just answer the questions.
How long do each of these stations go for in the Vivas and the clinical?
So the clinicals are 35 minutes.
Okay. And what about the OpSurge and the CIM?
They're 30 minutes.
Okay.
Yep. For the clinicals, everyone's aware that we've had major changes with the clinicals in the last 2 years with COVID, so there are no longer patients there. We talked about that in another segment. But the philosophy of the exam is the same. So in the video version of the clinicals, which is what we're doing now, a STEM is presented, and then there will be clinical videos or a clinical picture and some imaging as well. You might have even a little loop of an MRI or a CT might go up. All of these are done on PowerPoint, so it's hard to scroll backwards and forwards. So what you get is what you get. You might get individual cuts of a CT scan, or you might get sort of a little loop that helps with that. But they're all there to bring out specific points. In the clinicals, you may have a patient giving a history, and at the end of that history, so what do you think of that? What else might you want to ask?
Mm-hmm.
What disease process do you think is going on? Where do you want to go from here? And then the case will build from that. You might then have videos of a clinical examination to show specific things.
So it's like actually working a patient up in clinic
in
real life, but you get shown the history. Or you get shown
and one of the problems with a video format is that it is not the same as being in there with the patient. So we can't look at a candidate now and say, can this person elicit a knee infusion? You would expect that by the time you've been trained to the point of sitting the exam that you can elicit a knee effusion, but it's not always the case when people are under stress and their physical skills desert them sometimes.
Yep.
But the interpretation of somebody else doing it, what is this clinical science being shown? Why is that important? So rather than just say that is testing the medial collateral ligament too.
So would you say this is another exam section that's testing high order thinking in
Absolutely.
that case? This is about synthesis,
Yep.
interpretation,
Yep.
and then moving beyond that.
Put the history together with the clinical signs that you've seen and the STEM. So the STEM might say that this person has got multiple other comorbidities, and they've got a condition that is unlikely to be particularly helped by major surgery, and they're not really well enough. So your whole clinical scenario might be when not to operate rather than when to operate. And that's a fundamental part of surgery.
And is this another section where the keywords on that introduction page are very deliberate?
Yep.
Things like comorbidities or
Every
smoking?
Every STEM that you read, there are no redundant words. They've been worked out in great detail.
And they're all small pearls that might become part of the
And
answer.
don't feel afraid to say, can I look at the STEM again? And the examiners can go back through the slides and you can read the STEM again.
Okay.
I always had a thing with when we had patients, we would take the candidate into the room and introduce them. This is Pearl, she's 85, she's got a problem with her knee. And it would always irritate me when the candidate would then say, "Now, what's your name again? And how old are you?" You say, "No, I've just given you that information."
But it probably goes in one ear and out the other when you're stressed and walking into an exam.
You do understand it, and you do make allowances for it. But part of the art of being with patients is to listen. And so listening to the history, listening to the information you're getting, because when you're collating information, you can only collate what you remember. So practice remembering those aspects. What are the most important things about any patient? Their name, their age, their occupation, and then what's wrong with them.
Did you have an acronym of things you want to get out of a history?
For me, the history is about the history of the presenting complaint, and then a functional profile, pain profile, and surgical risk profile.
What's a functional profile? Is that what they can do?
What they can't do, what they've had to stop doing, how it affects them. So, you might say somebody who's got a sore toe who works at a desk all day might elect to allow nature to take its course and fix their toe and not have an operation. But a rigger on a bridge might be losing work and really want to have their toe fused.
So it's functional profile, pain profile, and surgical risk profile. I assume that's
risk profile.
Comorbidities.
Yeah.
Everything else.
So if I were to operate on this patient, in how many different ways could it go wrong? So for me, that was just a nice structure, so that if I'd forgotten something, I could go back and pick up the pieces.
And how far along this diagnostic and management process are we doing in the clinicals? Are we talking about operations? Are we talking about how we do operations? Or is it purely about obtaining diagnoses and maybe some initial management?
You do talk about operations, what the management would be, the actual treatment would be. I've got to be careful using those words because as we've said before, management has a specific connotation, treatment has a different connotation. But it's not in the same depth perhaps as OpSurg. So
but you still might be asked to describe what operation you do, maybe even how you would do it briefly, or
so for me the example is the bunion. What operation are you going to do for a bunion?
And why?
And there's 157 of them, and why? Why do you choose this particular thing compared to something else? And that might be an opportunity to throw in sort of recent studies and that sort of stuff that makes you make that decision.
So it's certainly a lot more than just a history and an examination that you have to interpret. It's actually going quite a few steps beyond.
It's a synthesis.
You might get
it's
some
a consultant
results.
Level assessment of this patient, and my advice is always view the patient on the screen or in front of you as your own patient. This is somebody who's walked into your rooms and wants your help.
Any other do's or don'ts for the clinicals? Tips?
I always say this, and it's quite hard, but you treat it as a conversation between colleagues. You're actually there discussing a case, not being grilled on a case. You don't want to go into the exam as a victim, you want to go in as a colleague. And, you're exploring options. You not necessarily have to have the one right option. And in fact, sometimes when people come in and they've only got one right option and won't think about anything else, that might indicate to the examiners a sort of a concrete thinking that won't pick up the nuances of a particular case. So be open to suggestions, to more information coming in, particularly with the clinicals and CIM, that you haven't seen the whole picture until the end of the case, and so making your mind up before then. It's pretty obvious if you walk into a room and you see someone with rheumatoid mutilans. The idea of that case is not after 17 and a half minutes to say, I think this patient's got rheumatoid arthritis.
Yeah.
It's to say, I think this patient has rheumatoid arthritis. Is that what they've told you? If you have a patient in front of you, these are the important features that I want to elicit from this patient. Prioritise. And it goes back to in the clinicals, that old, there are three types of patients. There's the management problem, the diagnostic problem, and the organisational problem. The same thing happens with the videos.
Okay. Rick, how does one prepare for the clinicals then? It sounds like it's almost everything orthopaedics that you could do in a consult and in an operating theatre. How do you prepare for that?
See lots of patients. The best preparation is going to be taking histories, examining patients, being at the bedside, old-fashioned outpatients. And a lot of candidates get a bit hooked on being in theatre, but it's very hard to do, the process of a clinical in an operating theatre. It's the operating theatre is much more where you learn op surge.
Yep.
So to be in the outpatients, dedicating time there. So
on the phone, calling the patients.
On the phone, calling the patients. Quite right, yeah. But also, most of the consultants now know that these are now video based. If you're in an outpatients and people can make a little video for you, call you into a room, keep the time.
Mm-hmm.
The other thing that's really important with all of the components is when you're practicing, if you're at bone school practicing, try and do cases in a row. Bone schools are often, you do this one, the next candidate does the next one, the next candidate does the next one. But in the exam, you're doing 5 in a row. So doing case after case on end is actually really good preparation.
It gives you more of a feel of that stamina and the resetting between cases, especially if you feel like you didn't do well.
Resetting is fundamental.
Yep.
You can't change something that's gone before. You just need to step through the next door as an absolute blank sheet.
Mm-hmm. Well, that's a good summary of the clinicals, and thank you very much for going through all the vivas and giving people a bit of an insight about what's involved, what you're looking for, and some do's and don'ts.